be discussing conduction system pacing. Conventional RV pacing, as we all know, carries the risk of pacing-induced cardiomyopathy and subsequent heart failure. In different meta-analyses and studies, it has been estimated that around 12% prevalence of pacing-induced cardiomyopathy exists. People have tried pacing RV from different positions like the RVOT or the RV apex, but the results have been equivocal. What happens when a patient has RV pacing is that he develops an LBBB. So what happens in an LBBB is that a normal QRS, which usually lasts for around 80 to 100 milliseconds, gets prolonged with the delay of depolarization of the posterior lateral wall of the LV, leading to intraventricular dyssynchrony and interventricular dyssynchrony. This LBB also leads to reduction in the diastolic filling time and prolongation of MR. All these things leads to hemodynamic compromise and heart failure. As we all know that the ventricular myocardium conducts slowly with a velocity of around 0.3 to 1 meter per second. However, the His-Purkinje system conducts quite rapidly at a velocity of around 1.2 to 2 meter per second. So the concept behind conduction system pacing is to pace this His bundle and its branches so as to depolarize the myocardium quickly and to have a narrow QRS and effective stroke volume. Why not CRT? So there are a few drawbacks of CRT, like it is a non-physiological activation. In CRT, we place a CS lead and it activates the LV through epicardium, which is non-physiological. Despite the recent advances, still 30% of patients do not respond to CRT, and we are highly dependent on the coronary sinus anatomy for the placement of the LV lead. CSP achieves a better uniformity in ventricular contraction by using the native conduction system of the patient, and it also bypasses the scarred areas, which does not happen in case of a CRT. Coming to the anatomy of conduction system, the point to note here is that the AV node continues as a bundle of His and it penetrates the fibrous bundle so as to continue into the bundle branches. The part of the bundle of His is above tricuspid wall and a part of the bundle of His is just below the tricuspid wall. So the bundle of His is actually inside the membranous septum. This membranous septum can be divided into two parts. One is the atrioventricular part, that is between the RA and the LV. Another one is the interventricular part which is between the RV and the LV. So the His lies in both these parts. If we want to do His bundle, His pacing or His bundle pacing, we can pace from both the sides, either just above the tricuspid annulus or just below the tricuspid annulus. The question which comes to our mind that in a patient who is having a left bundle branch block, how come that on pacing the His, the LBBB disappears? So the answer lies to this explanation that there is a longitudinal dissociation of conduction fibers within the His bundle. So if you look closely into this diagram, the fibers which are contributing to the left bundle branch are predestined. They are predestined in the bundle of His. Similarly, those fibers which are continuing as right bundle branch, these are arranged in the same order in the bundle of His. So if in any case we identify the site of block in the left bundle and we pace distal to this site of block, we might actually eliminate the left bundle branch block. It has been shown in multiple studies that in a typical LBBB, the site of block in 60 to 70% of cases is involving the proximal His bundle system. So what we have to do is that we have to identify the site of block and we have to pace distal to this site of block. Getting used to some terminologies, conventional biventricular pacing involves endocardial RV pacing and epicardial LV pacing. When we say that we are doing a His bundle pacing, we are placing the lead at the site of the His, which is just below the AV node and proximal to the bifurcation of the His bundle. A hot CRT refers to a His bundle lead along with an epicardial LV lead placed. Left bundle branch pacing refers to pacing the left bundle or one of its branches or the fascicle. Left bundle lead along with an epicardial LV lead, if they are placed together, it constitutes a LOT CRT. Coming to His bundle pacing. So when we do an EP study, we place a quadripolar catheter at the his area, and at that area we get this kind of a signal. So what you can say is that there is a signal called A, which refers to the local atrial activation. There is a sharper signal after A, which is denoted as H, which represents the his bundle depolarization. And at last there is a high frequency, high amplitude signal, which is denoted as V, which represents the local ventricular myocardial signal. So A, H and V, these all come in a sequence. If a patient has a block in the level of AV node, then it is the AH interval which is going to be prolonged, or it is the A which will not be followed by H. However, in a patient who is having an infranodal level of block, A will be followed by H. However, the H signal will not be followed by V. So this is how in an EP study we determine the site of block. So once we know the site of block, we can actually pace distal to it and eliminate the conduction system anomaly. So how to localize the his bundle in fluoroscopy? In RAO 30 view, which is actually similar to a two-chamber view, we can see the position of his denoted by the quadripolar catheter. It is just near the CS catheter at the base of the RV, near the annular region. The correct position of his is estimated by the signal. As you can see above, we have a sharp his deflection, a small A signal and a large V signal. This is the site where if we place a lead, we are bound to capture the his. So fluoroscopically in RAO view, the his bundle can be imagined at this position. Now what is selective his bundle pacing and what is non-selective his bundle pacing? The thing is that his bundle is surrounded by a very thick fibrous structure. So very often when we do his bundle pacing, we land up in giving non-selective pacing. So selective pacing refers to selective activation of the his. If in any case we have done selective his bundle pacing, what will happen is that there will be a pacing artifact or a pacing stimulus followed by an isoelectric interval followed by a QRS. So this isoelectric interval actually is analogous to the electrophysiological HV interval because we have captured the his selectively. So this HV interval will be the duration required for the impulse to travel after his bundle activation through the bundle branches to the Purkinje fibers and to the myocyte. In case of a selective his bundle, we can see surface ECG. Look closely at the lead V1. If we look at the lead V1, we can see there is a pacing artifact or a pacing spike which is not immediately followed by a QRS. There is an isoelectric interval which is analogous to the HV interval. So this kind of an ECG pattern is suggestive of selective his bundle capture. On the other hand, when we are capturing his non-selectively, what will happen is that when there will be a pacing spike, it will be immediately followed by a delta wave or pseudo delta wave. This is because now the local septal myocardium is also getting activated. So what we will get is that there will be a P wave followed by a pseudo delta, which represents the local myocardial capture followed by the rest of the QRS complex. However, if we are not even capturing non-selectively the his, then we will only get our LVBB like we get in case of a routine RV endocardial pacing. So this is the ECG, how it looks like when we have a non-selective his capture. There is a pacing spike which is immediately followed by a QRS and there is a pseudo delta wave visible in the lead 1. So how to identify whether we are having a non-selective capture or a selective capture? So we have to pace at different outputs while we are doing the his bundle pacing. So when we are pacing at an output of 1.2 volts at 1 millisecond pulse width, we can see in lead V1 there is a spike which is followed by a delta wave and the QRS is slightly broad. However, on reducing the output to 1 volts at 1 millisecond pulse width, you can see there is a clear-cut isoelectric interval between the pacing spike, and this isoelectric interval is followed by a narrow QRS. This isoelectric interval, I repeat, is analogous to the HV interval. So if you are having the pseudo delta, no isoelectric interval, it is probably a non-selective capture. If it is a selective capture which is occurring at low output, it will not capture the myocardium, so there won't be any delta wave. So this was the first study done by Deshmukh et al. In 18 patients with the AF and fast ventricular rate and LV dysfunction. So what they did is that they did AV nodal blockage because these patients were not having adequate rate control. After blocking the AV node, they subjected the patients to His bundle pacing. So fluoroscopically, they took the help of His bundle catheter. They did EP study in these patients and localized the exact site of his and then put a permanent lead at that position. So whenever we do a His bundle pacing, the morphology of the QRS and T wave is similar and the direction of activation is similar to that of sinus activation. So the QRS and T concordance is there. Secondly, the HV interval is the same as the pacing stimulus or V pace to V interval. And there is no QRS widening at low output because we are capturing the His bundle selectively and not capturing the myocardium. This is one of the ECGs in their studies. As you can see, it is very difficult to make out any significant difference between the intrinsic QRS and a paced QRS. Why? Because we have selectively captured the His bundle. So long-term distal His bundle pacing results in a reduction of LV dimensions and improved cardiac function as demonstrated by this study. However, there are a few cons or drawbacks of His bundle pacing also. Like I told you that His bundle is actually a fibrous region. So over long term, it is seen that the output required to capture, that is the thresholds, increase. And this area is very unstable. The lead is quite unstable in this position. So there is a frequent tendency of the lead to fall. Besides this, what I showed you in the anatomy slide, the area of the His bundle, that is the membranous septum, is quite close to the tricuspid valve annulus. So at that location, there is a very high chance of having atrial oversensitivity and oversensing and ventricular undersensing. So all these are the fatal flaws of His bundle, due to which now practically it has vanished from the clinical scenario. No one now is doing His bundle pacing. What is going on is the left bundle pacing. So left bundle pacing is defined as the capture of left bundle with simultaneous activation of its fascicles. However, when we practically do a left bundle pacing, we not always end up in selectively pacing the left bundle. We might end up capturing the left bundle, we might end up capturing the anterior or the posterior fascicle. We might even end up in doing the deep septal pacing or the LV septal pacing. So suppose if we have placed the lead in the correct position and we have selectively captured the left bundle as shown in the A diagram of this figure. So what will happen? We will have a very short LV activation time. So what is an LV activation time? LV activation time is the time from the pacing stimulus to the peak of R wave. This is also known as V6 R wave peak time. V6 R wave peak time or the LV activation time. So the more selectively the left bundle is captured, the lesser will be the time of the QRS complex and the lesser will be the time of the peak to R wave. So the lesser will be the LV activation time. As you can see in this A diagram, we have captured the left bundle selectively and the LV activation time is just 75 milliseconds with the QRS duration of 125 milliseconds. In case we do not get deeper into the left bundle and we end up reaching up to the LV side of the septum or the endocardial side of the LV septum, we call it LV septal pacing. In case of LV septal pacing, as shown in diagram B, we can see the ECG, it has a relatively longer LV activation time of around 93 milliseconds and a QRS duration of around 138 milliseconds, which is broader as compared to what we have got in selective left bundle capture. In worst case scenario, we might end up doing a deep septal pacing, not even capturing the LV side of the septum. In case of deep septal pacing, again the LV activation time will even be longer and the QRS will be broader. And multiple studies have shown that deep septal pacing does not help. It does not help in reverse remodeling. It does not reduce the cardiac dimension, and it is of no use. So this slide summarizes how to identify what we have captured. So if we have captured the left bundle selectively, you will have an RS-R dash pattern in lead V1. So it is just like we have captured the left bundle, there will be an RBBV morphology. When we capture a right bundle, there is an LBBV morphology. So if there is an RS-R dash in V1, we should not have any doubt we have captured the left bundle, and that too selectively. If in any case we do not have an RS-R dash, we have not captured the left bundle selectively. So if the LV free wall activation time or the LV activation time is short, less than 80 millisecond, and their RV activation time is delayed, or there is an R dash in V1, it means we have captured the LV septum plus the left bundle, which means we have non-selectively captured the left bundle. So in short, if there is an RS-R dash, it means we have captured the left bundle selectively. If there is no RS-R dash, but there is R dash, then it means that at least we have got a non-selective left bundle capture if the LV activation time is shorter. However, if we have an R dash in lead V1, but the LV activation time is not short, it means we are still superficial. We have reached only to the LV side of the septum. And if none of this thing is there, there is no R dash, there is no shortening of the LV activation time, then we are probably in the deep septal area. We have not achieved a good result. Sometimes we want, not sometimes, I should say most of the times, if we don't do any maneuvers, we will end up doing a left fascicular pacing. So it is characterized by a short potential to QRS interval of around 1 to 25 milliseconds. And it does offer advantage that pacing lead far away from the tricuspid wall. So how to identify whether we have captured the left bundle or the anterior fascicle or the posterior fascicle? So it is very simple. When we have a left anterior fascicular block, so the ECG which we get when we have a left anterior fascicular block, we have a dominant R wave in one AVL and a dominant S wave in inferior lead. The similar ECG we will get when we capture the left posterior fascicle. Similarly, when we capture the left anterior fascicle, we will have a surface ECG similar to left posterior fascicular block. And when we capture the left bundle, we will have an RS-R dash RBBV pattern in lead V1, S in 1 AVL similar to that of sinus rhythm, and R in 2-3 AVF similar to that of as in sinus rhythm. Coming to the implantation tools for left bundle branch pacing. Initially, it was only Medtronic which used to provide a lumenless lead, that is the Select Secure 3830 lead, compatible with the C315A sheath for left bundle pacing. But now, as the competition has grown, different players have come up. We have a stillet driven lead provided by St. Jude, Boston and Biotronic. We do have pre-shaped or pre-curved sheets which have primary and secondary curve, which makes it very easier to direct the lead towards the septum. So now we have stillet driven leads and Medtronic only is supplying the lumenless leads. There are some significant differences between a lumenless lead and a stillet driven lead. One of them is torque transfer. So in a stillet driven lead, you have a stillet inside the lead, you have a sheath outside the lead. So the torque transfer is better. Moreover, the power of penetration is more. However, since these leads have come up recently in the market, so we do have less experience with these. Coming to the implantation technique of left bundle pacing, pre-procedural we need to see the thickness of the LV septum. So there is no universally accepted thickness, but it is said that if the septum is at least 8 to 10 mm, then we are in the safe zone. If it is thinner than that, then we might actually ending up doing an septal perforation. Intracardiac EGM and 12-lead ECG monitoring is continuously required. Using an EP system with the and doing an EP study is only optional. So how to proceed? First, we localize the position of the left bundle fluoroscopically, which is followed by pace mapping at that site. So when we pace map at that site, we should get a W pattern or an LBBB pattern in lead V1. Now, we will start screwing the lead at that position. For screwing, we have to do rapid clockwise turns. During this lead deployment, we have to continuously see the surface ECG for the morphology. Once we are sure that we have reached the correct position, we have to confirm the depth of the lead with the help of ECG and signals, and we have to confirm the left bundle capture. Starting with the fluoroscopic localization of the left bundle, again in the RAO view, if we draw an imaginary line from the his bundle to the RV apex, which is denoted by this yellow dotted line in this image, and we take a position around 1.5 centimeter below the his bundle, this is exactly the area where the left bundle lies. So this is an imaginary line, and this, however, this helps a lot. So once we know fluoroscopically that this is the area where we expect the left bundle to come, so we can position our lead in this area and do pace mapping. When we pace map, we expect a W pattern in lead V1, a tall R in lead 2, RS pattern in lead 3, and discordant QRS complex in AVR and AVL. After getting assured that we have a W pattern in lead V1, now we start screwing the lead inside the septum by doing rapid clockwise rotations. So lead deployment involves two strategies. One is conventional method, another is VPC guided. So in the conventional method, what we used to do is that we used to do gradual screwing, and then we used to see the paced QRS morphology, whether it is RS R' or not, whether the current of injury is good or not, and whether the unipolar impedance is within the normal limits or not. Suppose if we find after screwing that the RS R' still has not come, then we will continue to screw. In the second method, that is the VPC guided method, we deploy the lead very rapidly by doing very quick clockwise rotations while monitoring the VPC morphology. While doing this maneuver, we have to give a firm counterclockwise torque to the sheath so that it abuts the septum and it makes itself perpendicular to it, which makes the screwing of the lead inside the septum easier. Coming to the conventional approach, we can see in this diagram that we are screwing the lead inside the septum, and as we go from left to right, we are going from the RV subendocardium to the mid septum and then to the left bundle area. So when we are at the RV subendocardium and we have just started pacing, you can see that there is a W pattern or an LBBB pattern in the lead V1. Now when we continue to screw and continue to do clockwise rotations, you can see when we have reached the mid septal area, there is a positive deflection at the end of the QRS. That is, now we have started to get R'. Now if we continue to do further screwing, we will finally get an RS R', and this RS R' in lead V1 means that we have captured the left bundle selectively. So it is not only the surface ECG which guides us, it is also the impedance value. If you look at the lower side, the impedance is continuously increasing as we are screwing the lead inside the septum. So it goes on increasing from 400 to 660 to 750 till 940, and then it slowly starts decreasing. If we continue to screw beyond the RS R' pattern, so once we get an RS R' in V1 and we continue to screw it, we might land up perforating the septum. And once we perforate the septum, the impedance will fall sharply to less than 400 or 500. So we have to be very careful once we get an R' in the surface ECG. So I repeat, we have to see three things while screwing the lead. One is the surface ECG. We have to target for R' and RS R'. Second, we have to see the impedance. Initially the impedance rises, but if there is a perforation, it will be falling very quickly. The third thing to look for is the current of injury. So when the septum and the lead are having a very good contact with each other, we expect a good current of injury. As you can see in this diagram within the red box, the current of injury is very good on the left side. However, when we continue to screw the lead, suddenly the current of injury falls and there is an ST depression. So this kind of a figure of ST depression and a sudden fall in current of injury again means that we have perforated the septum. Can CSP be done without EP study? Yes, CSP can be done without an EP system. So we can use the routine programmer. The programmer will give us beat to beat impedance, which will be told to us by the technician, and also it will give us the current of injury. After screwing few turns, we can wait and see the threshold and the morphology of the surface QRS. However, it is always good to have an EP system with you. So this is a live demonstration of a patient who is undergoing left bundle pacing. If you can see, initially there is a small R dash in lead V1, and at the end of this there is a very good R dash or RS R dash which comes when the notch moves upwards. So this RS R dash means that we have captured the left bundle selectively. So it is also written that impedance increases from 300 to 790 and then suddenly to 620. So when there is a sudden decrease in impedance, you have to be very careful. Another image showing continuous pacing while rotating, giving clockwise turns to the lead. On the left side, you can see we have reached only to the deep septal area. So there is LLBB pattern. While we continue to screw, we reach the LV septal area where we have a small R dash there and a short, relatively short LV activation time. But still we don't have an RS R dash. And only once when we reach the left bundle branch or when we capture the left bundle branch, then we really have an RS R dash in lead V1. So when should we be cautious? When the paced QRS morphology of RVV pattern comes and the impedance drops to approximately 600 ohms, at this situation, we should be very careful in screwing. So now we should screw only half turns. And suppose if the sudden impedance drop is more than 200 ohms or the unipolar impedance falls to less than 400 and there is a sudden reduction in R wave with the loss of current of injury, you have actually entered into the LV. Most of the cases, the LV perforations are not dangerous. We can reposition the lead. However, we don't know when it will be fatal. Another approach which I told you is that VPC guided lead deployment. So what happens is that instead of giving slow rotations, we can give very rapid movements, and during these rapid movements we have to look for the morphology of the VPC. The morphology of the VPC, that is known as the template beat. So once we have a VPC with the morphology of RS R dash, we have to stop it at that point. That's the VPC guided lead deployment approach. So here you can see in this box that we are screwing the lead really rapidly, and initially we have few VPCs of LBBB morphology, then there is an R dash, and then there is a frank RS R dash, and this is the time that we stop. Advantage of this method, VPC guided approach, is that it takes less fluoroscopy time and there are less chances of perforation. Successful left bundle capture. So now we have screwed the lead. We think that we have captured the left bundle. Now we have to make sure that we have captured the left bundle selectively. So what all parameters to see? On the surface ECG, we should have an RS R dash or a QR in lead V1 plus a local left bundle to local V EGM interval of 20 to 35 milliseconds. Transition in QRS morphology from non-selective to selective with decremental output. And peak LV activation time should be less than 80 milliseconds. This is a flow chart or an approach how to do left bundle pacing, which we have already discussed. Coming to complications. So left bundle branch pacing is associated with few complications like septal perforation. There can be a septal hematoma which can be dangerous. There have been case reports of coronary artery damage, septal venous channel perforations, and even lead damage during implantation. Let us discuss one of the cases done at our institute. So there was a 75-year-old male, known case of CAD. He had severe AS with moderate LV dysfunction, underwent CABG plus AVR. Post-operative ECG had a complete heart block. The patient was totally dependent on epicardial pacing wires. This was the echocardiography. You can see that the LV septum is quite thick. It is actually more than 16 mm, and the contractility is compromised. So in these patients, it is a class 2A recommendation. We can go for doing a CSP or we can do a CRT. In this patient, we opted for doing a LOT CRT, that is putting in an LV lead along with a left bundle lead. So initially we put in a CS lead or an LV lead, and then we proceeded with doing a left bundle lead because the QRS was not that good. So on this screen you can see the lead V1 in green color, which is showing the surface ECG. The yellow one is showing the current of injury. So on the left side of the tracing, you are seeing that there is just an W pattern. However, when we start screwing the lead, we start noticing a gradual upstroke or a deflection, positive deflection at the end of QRS, which is the R dash, and a good current of injury. Now when we continue to screw, you can see at the end of this strip that the R dash is still there, current of injury is still there. Meanwhile, the impedance is 790, we have a good R dash, but still we don't have a good RS R dash, it's just QR. So in order to have a narrower QRS, in order to have an RS R dash, we still continue to screw the RV lead or the left bundle lead, and the impedance became 680. So at this time, we screwed very slowly. However, the current of injury fell. You can see that the current of injury fell with the decrease in impedance, and although we were now screwing very slowly, still the current of injury fell further, impedance became 450, and the RS R dash was eventually lost. So this was the moment when we perforated the septum. Fortunately, the patient was asymptomatic, there was no event. We then changed the position, and after repositioning, you can see we have now a good RS R dash in lead V1 with a fairly good current of injury and a QRS duration of 128 millisecond with the R wave peak time or the LV activation of time of just 15 milliseconds. So these are the fluoroscopic images of the patient. We have already placed the CS lead. Now we are screwing the left bundle lead, and finally we have removed the sheath and then slit it. So this is the left bundle lead as visualized in the echocardiography. Post-op procedure ECG shows a narrow QRS. Coming to the indications and guidelines of doing a left bundle pacing, at present, there is no class 1 indication of doing a left bundle or a his bundle pacing. The only indication is class 2A. So for those patients with indication for pacemaker therapy, that is those patients who require permanent pacing and who have LV dysfunction and in whom the anticipated ventricular pacing is substantial, for these patients, we can do a CRT or we can do a CSP. Both stand in class 2A. Another indication is for those patients who have LBBB with an LVEF of less than 35%, who are symptomatic and who have received CRT, but they have shown no response to CRT or they are non-responders. So for these patients also, it is a class 2A recommendation to do a CSP. As far as patients with AF are concerned, there is no class 1 or 2A recommendation. CSP is just class 2B recommendation. Another case scenario, 75-year-old gentleman with dyspnea, high-grade AV block and mild LV dysfunction. What device will you recommend to this patient? A CRT, considering that he is having LV dysfunction and AV block, or a conduction system pacing, considering the same. So for this patient, he is going to have high anticipated pacing requirement because of high-grade AV block. We can choose either of these. We can go with a CRT or we can go with the left bundle pacing. So there have been multiple studies which have compared his bundle pacing or left bundle pacing to BiV pacing or CRT, and most of these studies have shown that there is actually no significant difference between these two different intervention arms, and the patients which they took were those of heart failure. Indeed, one of the studies has shown that there is a greater EF improvement and reduction in LV end systolic volume with left bundle branch pacing. A recent study published in 2023 by Vijay Raman et al. Has shown that the time to death or heart failure hospitalization is less in case of left bundle branch pacing as compared to biweekly pacing in patients of heart failure. A few other studies which have actually demonstrated non-inferiority and even superiority of conduction system pacing over the conventional biweekly pacing. However, we still do not have large data. Randomized control trials continue to go while I am speaking to you, and it is quite possible that in the near future we have a class 1 recommendation for conduction system pacing. Thank you very much.